Edwards, and I'm the Donor Support Manager of Transplant Australia and a living kidney donor. I'd just like to apologise if you've been waiting in the wings to come onto the webinar tonight. We just had a couple of technical issues that we didn't expect, so we're working on those. On behalf of Transplant Australia, I'd like to welcome you to our webinar on living kidney donation. And I'd like to thank Professor Richard Allen for his inspiration in creating the webinar and helping to coordinate the organisations who've helped put this together. There'll be a couple of housekeeping rules that will just basically, if you make sure your phones are off, there's no other sort of static or volume in the background or noises, we'd appreciate that. And thank you for joining us. Over the years, I've had an opportunity to meet many living donors, living kidney donors, and many people who are considering becoming living donors. It's a huge decision. You have the opportunity.
Output level. Can you do it up a little bit? Don't hear a ringtone.
Can you please, could people mind muting who are listening to the presentation so that we don't hear your voices? We'd appreciate that. Thank you. So over the years, I've met many living kidney donors, and I've also had an opportunity to speak with many people who are considering becoming living donors themselves. It's a huge decision. You have an opportunity to make an enormous difference to someone else's life, but you have to consider the impact and the health risks on your own life.
What's going on?
Dan, if you could mute yourself.
What?
Thank you. Thank you. I'd just like to say I donated a kidney to my brother Mark 30 years ago.
Do you have any problem? I don't have problems with this. Is that on again now? Yeah. People have got to stop taking it away from the computer.
You took it away.
Are you able to mute, Jan? Thank you. Thank you.
Unplugged. It's not unplugged.
I took this out and then it worked properly.
We'll plug it back in again for a minute.
Thanks, Jan.
Thank you. I was just explaining that I donated a kidney to my brother over 30 years ago. I wanted to do all I possibly could to help make him well again. It was a decision that I was comfortable with and it felt right for me. I had a great medical team who explained everything, answered all my questions and supported me all the way through.
Hang on, what's it say?
Even to today, with all the medical checkups I've had, even last week, my annual checkup. This webinar covers the important aspects of living kidney donation. There'll be a panel discussion towards the end where your questions will be answered. And now I'd like to introduce our facilitator, Professor Carol Pollock, who's Deputy Chair of the Australian Organ and Tissue Authority and Chair of Kidney Health Australia. Thank you, Carol.
Thanks so much, Julie. And I'm aware of your considerable donation to your brother Mark, because I was at North Shore Hospital when Mark was a recipient of your kidney. So I'd known him for many years. So it's a small world in transplantation. So I think, as you've mentioned, that the topics that we're going to be discussing today are the role and the value.
I have problems with any of these things.
Of living kidney donation. We're also looking at the clinical safeguards for people who actually are looking to donate kidneys. We're looking at how matching of recipients and donors might be benefited by living donation, and also the long-term follow-up. What are the risks for people that donate kidneys? So if I can just start by acknowledging the people that are important to this webinar. And I'd firstly, like to acknowledge Transplant Australia for supporting this webinar and I know, Julie, you're intimately involved with Transplant Australia. But also, if I could just also acknowledge the people from Transplant Australia who've been instrumental in putting this together, which Richard Allen and Matty Hempstalk, Colin Liebman, Chris Thomas, and I'm sure there's others. There's a whole lot of support for activities that go on around Transplant Australia, and particularly relating to living donation, and these are recognised on this slide. I think just if I can set the scene, this looks at living kidney donors per month. Now, I've actually got some figures down to or back to 2009. In 2009, there were 327 people that donated kidneys for the purposes of living donation. That has fallen quite significantly in 2020. Well, say we go to 2018, where it was 238 donors. So 327, and then, like almost 20 years later, 10 years later, we get to 238. And that number really hasn't changed. So although we have had an increase in deceased donors over this period, where we've had 501 donors in 2018, we've actually reduced our living kidney donor rates. And in fact, 501 in 2018 went to 490 in 2019. And obviously there have been issues in 2020 with COVID, but we only had 391 donors, and thus far in 2021, we've only had 183 donors to date, which are the latest figures. So although after the inception of the Organ and Tissue Authority, we've had an enormous increase in cadaveric donors, we've had a parallel reduction in living donors. We've also been able to implement the AKX, the Paired Kidney Exchange Program, and that has actually delivered more kidney transplants for more living donors and recipients by virtue of paired kidney exchanges. But that number as well has been falling. So we had 50 in 2019, we only had 29 in 2020, and thus far in 2021, we've only had 17. Now, of course, we've been impacted by COVID and things outside of our control, but I think it's worthy of discussion. So we have an excellent team who we've assembled today to facilitate this discussion. We basically have a discussion initially from a transplant, a living donor person, and I'll introduce him. We also have Emma Hardveld, who was a living donor transplant coordinator at Royal Melbourne Hospital for many years, and now is the Paired Kidney Exchange Coordinator for the Organ and Tissue Authority. We have Professor Kate Wyburn, who is the Director of Transplantation at Prince Alfred Hospital and the President-elect of the Transplant Society of Australia and New Zealand. We have Dr. Christine Russell, who's joining us immediately following her undertaking a living donor transplant procedure from Royal Adelaide Hospital. And we have Associate Professor Phil Clayton, who's a transplant nephrologist and epidemiologist, who is going to give us some information about the long-term and short-term outcomes of being a kidney donor. So I think with that introduction, I'd just like to introduce Dr. Michael Wines. Now, Dr. Michael Wines is in a very unique position in that if anybody has walked the walk for kidney transplantation, it's Dr. Wines. He is a urologist who works with within our kidney transplant team and is part of the team that operates on cadaveric donors and supports the outcomes that we have for cadaveric kidney transplantation. So, Michael has a unique story to tell, and I'd just like to hand over to Michael, who can, talk about his decision to be a kidney donor.
Thank you very much. Now, I'm a urologist who's taken out over 500 kidneys over the last 20 years, and I've probably been involved in around 150 transplants. The part that I do is reasonably simple, where I actually just plug the ureter into the kidney, and I'm probably a lot less involved than most of the other speakers tonight. My wife and I went over and saw our next door neighbours for drinks. They're people we see a couple of times a year. They're not our besties. And she was having a little cry because she was in kidney failure, and a couple of her friends had dropped out, and she was scared that she wasn't going to make it to her daughter's weddings. My wife came home that night and we had a discussion, and we decided, well, we can probably do this. We've got 4 kidneys, we need 2. We can give 1 away, and we've still got 1 spare for the kids if they ever need it. As a result, we then went through the Royal North Shore program in terms of having a workup. We did it anonymously, and we didn't tell our neighbour until we were a long way down the process. Most people at North Shore take between 6 and 9 months to do things. Obviously, it can be done quicker, and I think my wife did it in 3 weeks, which may have been a near record, and I did it in about 4.5 weeks. After some time, I decided it was me going to go ahead for a number of other reasons. On the image you can see on the right-hand side are 2 reasonably handsome looking kidneys, because they're mine. One of them, the one on the left-hand side, no longer belongs to me. On the right-hand side, my neighbour has a condition called polycystic kidney disease, of which a number of you will have, of which the kidneys down here and over here become very large and full of cysts. And the condition actually also affects the liver and can cause problems. The workup process can be done quickly, and certainly one of the speeches tonight will give you some lead in, and I'm very happy to provide any commentary regarding that. The operation hurts. There's no 2 ways about it. My operation started at 4:30 in the morning because my kidney was being flown interstate as I was a paired donor. Somewhat alarmingly, my kidney was on a Jetstar flight, which my wife and I still have a chuckle about a number of years later. I was in hospital for 5 days. The operation hurts. There's no 2 ways about it. The image that hopefully you can see on the left-hand side, I've got a number of small ports where the kidney was taken out laparoscopically. And just on the lower part of my abdomen, there's a large cut, which is the same cut that women get if they're having a cesarean section. So the kidney can be whipped out reasonably quickly. I stayed in hospital for 5 days. I then had a reasonably steady recovery. The photo on the left is me trying to have a beer that I was unable to drink at day 7 post-operatively. By day 14, I was up to 2 beers and a coffee, and I think I went for a walk for about 5 or 6 kilometres. And then by 3 weeks, I was back at work and back to a fairly full schedule. Certainly anyone who does it, just get up and walking. Don't sit there and wait till the pain goes away, because the pain takes quite some time to go away. I'm very happy to discuss later on any parts of the process that you'd like some guidance for. The experience is certainly a roller coaster, and I think it's very important that you do talk to the right people in terms of the social worker, the psychiatrist, as well as everybody. I think one really interesting point is 30% of people actually suffer some degree of depression after being a donor. And there are a number of reasons that occur. At the end of the day, you're giving somebody a gift, which is life altering. If you're on dialysis full time, if you work out the hours, it's potentially 1,000 hours a week. You'll be the same person once it's done, because the team will make sure that that's the case. And you're really giving somebody a wonderful gift. Thank you very much.
Thanks so much for that. That's very powerful, Michael, because of all people, you know, you've been on both sides of the journey. And, you know, I think that, you know, that gives a really powerful perspective. So the only thing that I just really also want to reiterate is that the waiting time on the cadaveric list is currently 2.1 years, which is the median wait. There's a lot of people who wait a lot longer than that. And that obviously impacts on their life, their family, and their economic ability to, you know, maintain their lifestyle. So I'd just like to personally thank you, Michael, for, you know, what you've done for, you know, the individual, but also, you know, for being here to support people who are thinking and maybe ambivalently about donating a kidney. So that brings us on to, you know, the subject that you raised, which was that you did this anonymously, and you basically underwent the assessment as to whether or not you or your wife could be a donor. So I'd like to ask Emma, who's obviously got the expertise as a living donor coordinator and now with the ASX, to give us her perspective on, you know, how she approaches the issue of kidney donation when somebody puts themselves up.
Thanks, Carol. I'm just going to share my screen. Sorry, it's going to take me. Okay. Can you see that?
Not yet.
Right. Can you now? Can people see my screen?
No, I can't.
Okay.
So if you go to the bottom and...
Yeah, no, I did.
Okay.
Wait a second, I'll do it again.
Just while you're waiting, we've got some comments saying that that's a fantastic story, Michael.
Thank you.
Ah, yes, we can see it now.
See it now? Okay, great. Okay, so as Carol said, my name's Emma, and I'm just previously I was a transplant coordinator and predominantly with the living donors at Royal Melbourne Hospital up until for about over 10 years before I started the job as the program coordinator of the Australia and now Australia and New Zealand Paired Kidney Exchange, which unfortunately has been interrupted a little bit by COVID, but hopefully we will be resuming in the near future. So there's a process that people go through as being assessed for as a live kidney donor. And really the first thing, hopefully, is to learn as much as you can about the process and about donation and about what it entails and what it means. I think it really needs to be discussed with your family and friends because it is a major decision and need the support. It's a really difficult process to go through if you don't have the support of your family and friends. So people find out about kidney donation, you know, in many different ways, but so usually the first point of call is to contact the transplant coordinator. The transplant coordinator will sort of explain a little bit more about the process, and they'll also ask you some questions, and that those questions will be about your current health status, your past medical history, and also some social issues and, you know, situation and stuff as well. So I'm not going to go too much into the medical side of it because Kate will be talking about that in the next topic. So really what the coordinator will do, will go through this process, and if we think that you would be as a potentially suitable donor, is usually we would ask you to go and do some initial tests with your GP. And, you know, we'd give you a list of tests or a letter to take to your GP. And then you'd get a referral to see a kidney specialist. And then the process of all of the workup and the tests and the investigations and the appointments start. And as Michael said, that can take quite a significant amount of time. So the workup tests, the, you know, blood tests and urine tests and x-rays and things like that, they're looking at your health status, but they're also seeing, will you be okay with a single kidney for the rest of your life? Then there's also the test to look at the kidney function and the structure of the kidneys, and will that be suitable to be a transplanted organ? And then also there's the compatibility testing. Are you compatible with your intended donor, or are you not compatible? Although these days there is ways to sort of overcome incompatibility with the paired kidney exchange program or different types of transplant. After you've had all of the workup process, obviously then there's the stage of the operation and recovery. And then it's really important for ongoing health and maintenance of health and keeping a healthy lifestyle and, you know, keeping your blood pressure under control. And so we really recommend that people continue having annual checkups for the rest of their lives. Sorry, yeah, it's not going. Okay, so who can be a living kidney donor? As Carol mentioned, unfortunately, the numbers of the live kidney donors have been going down over the last decade. But with regards to who is the donor, it's still maintained that probably most donors are genetically related, so parents or siblings or grandparents and things. But there's also what's considered emotionally related is spouses, and spouses, you know, are very common as donors because, you know, if their loved one or their spouse is unwell and on dialysis, that affects their lifestyle as well. So that's the emotionally related. Kidney exchange, as I said before, is when you're incompatible with your intended recipient. And you can go into a program where you would potentially donate to another person and their donor would donate to your recipient. And that's called the exchange. The donors in the kidney exchange program are a bit of a mixture of emotionally related and genetically related. So any donors can go into the paired kidney exchange. And the other is what we call the altruistic donors or the non-directed donors, which is a person who, out of the goodness of their heart, will donate to someone that they don't know. So I was just going to quickly mention altruistic donors. And that's a picture of Paul, who was an altruistic donor who I worked up prior to going into the paired exchange role. Altruistic donors are not common in Australia, and if you're on the internet or something like that, you'll see in the US and other countries they are very common, and in New Zealand they actually have quite a few more altruistic donors than Australia does. There's different rules around altruistic donors in each state in Australia, and that's all to do with the legislation and the Human Tissue Act. And some states require the donor to be presented to a group to see whether they're acceptable. The assessment for altruistic donors usually takes longer than a directed donor or somebody who knows their recipient, because this is, you know, what are they going to get out of doing this? You know, they're donating to somebody that they'll never know. It is anonymous, so they never will potentially know who they've donated to. Usually these people do have a history of altruism, like Paul, I know, was in the CFA. So he's sort of always been very active in his community. So, you know, maybe there are certain people who are amazing and do these sort of things. There's a very intensive psychiatric assessment for these donors. You know, all donors do have some level of assessment with either a psychologist or social worker or psychiatrist, but we seem to be a lot more conservative when it comes to the assessment of the altruistic donor. An altruistic donor can donate directly to the transplant waiting list to a person who's on the waiting list, and it usually would be aimed towards somebody who's very sensitized and very difficult to find a potential donor for. Or they can donate to the Paired Kidney Exchange program. And what that does is they start off a chain, and they can start off a chain of transplants where they will donate to a recipient, and their donor will donate to a next one, and that will go on as long as we can. And the last donor then goes to the transplant waiting list. So the exchange, Paul donated to the Paired Kidney Exchange, and he started a chain where they ended up being 7 transplants, which was amazing. So also, who can be a live kidney donor? They must be a healthy individual who is able to undergo surgery and be able to live with a single kidney after donation. I'm not going to go into it too much, but just age. There seems to be a little bit of a preconception in the public sometimes that you need to be young to donate, but that's actually not necessarily true. So as you can see in this graph, the average age of, sorry, and I've covered the average age of, or the highest group of donors in Australia is actually between 45 and 54. And the next group is between 55 and 64. So we actually don't have that many donors between 18 and 24. And there's some that are 75 and above. Obviously, the numbers are quite small there. Saying that, I've got a picture there of a pair that I assisted with their workup. And they were both in their 70s. They were 73. Yvonne donated to her husband, Brian. She was very adamant that she wanted to do it, and which was, we had a few concerns with regards to her age and some other issues. But she was adamant that she wanted to do it. She said that, you know, they wanted to travel, and, you know, her life was affected by him being unwell. So eventually we did go ahead with it. She was amazing. She was out of hospital within 3 days at 73. And that was 14 years ago, and they are still going strong. So both of them are still well at 87, which is amazing. So just from a little bit from the recipient's point of view, I mean, this is such a difficult topic. How do you ask somebody or talk to them about donation? And that can, the type of conversation you can have really depends on the relationship that you have with that person. You know, a lot of times, you know, the person who who is their donor has been to some of their medical appointments with them, so may have some background in it. But, you know, sometimes it might be friends. But what we hope is you can learn from a recipient's point of view is that you learn as much as you can to explain to your family and friends, but also including your treatment options with regards to dialysis and PD and all of those sort of things. Share your story about living with kidney disease. What are the symptoms like? How are you feeling? What is dialysis like? You know, if you're spending 5 hours 3 times a week on a machine. And, you know, sometimes if you're not able to have these conversations and don't feel comfortable about it, sometimes some of your family or friends may be willing to talk to others about your situation. There's also social workers as part of all teams, And so they can also assist you with some ways of talking to people about it. We all know that social media is all part of our life now, but we just sort of use social media and technology with a bit of caution. I mean, if you have a Facebook group which is closed to your friends and family, then, you know, that might be a way of telling people what's going on in your life. But just be careful. And then going back to the donors, there's a lot to consider when you're potentially thinking about donating. Why do you want to donate or not donate? And there's lots of reasons for that. Are there other potential donors for this recipient? So, you know, are you in a family with multiple siblings? Is it a child with two parents? You know, is there multiple cousins or friends? And it's quite common for us to actually work up a few donors for one recipient. And then if the testing looks okay, then sometimes it's good for the family group to decide who would be the better donor, or who was, you know, and that could be because of work or other family members or things like that. So, you know, it's always something to consider. How would you feel if it wasn't successful? Live donor kidney transplant rates have a very good success rate. However, there's always some cases that potentially might not be successful. So how would you feel if you went through this process, all of the testing and the operation, and then the recipient, then it didn't work? So these are things that you have to think about. Do you expect to get something back from it? And I think that's a really tricky one. So, you know, you can't expect to get anything back from it. So it's an amazing gift, but, you know, and obviously the receiving money for an organ in Australia is obviously illegal. So although, you know, some people find the donors find the whole process and it's very rewarding from an emotional point of view. You also have to think about, do you have the support of your family and friends pre and post donation? So to support you going through the tests, support during your hospital stay and post donation. If you've got family, do you have somebody who's going to look after your children? After an operation, you can't drive for a little while. Do you have somebody who can drive you around? Also, do you have time for the testing? You know, some of the tests can take a little bit of time. There's multiple visits. So, you know, are you able to take time off work? Can you financially afford to do it? There is a fund by the government called the Support for the Living Donor, which can cover some of the costs of time lost from work, but that payment goes to your work and it's at minimum wage. So there is a maximum of how much that can cover. So also, are you potentially willing to modify lifestyle factors? Kate might go into it with regards to smoking. You know, if you're a smoker, are you willing to give it up and give it up for not just the operation, but for forever? Also, there may be people that might need to lose a bit of weight. And how are you going to feel if you go through all of these tests, or you get to a certain point in the test and something comes up and you can't donate? And, you know, that does happen a lot. We do look at and work up quite a few donors that actually don't proceed to donation. And then back to the recipients, how do you handle the responses? You know, it'd be quite normal to feel disappointed if somebody doesn't offer or actually says no. But usually it's not necessarily about the recipient, it's just not the right decision for that particular person, whether that be work, family, or just being very nervous about it. But it can also be challenging if someone says yes, and it can be overwhelming that someone's willing to go through this major process and major operation for you. And so you could be worried about the risks for them. You know, no operation is 100, you know, so there's risk associated with all operations and anesthetics, and also their future health. So, but if somebody is interested, what we would say is to give the details of your transplant coordinator to that person, and they can contact them and get more information. But if people are going through the process of being assessed as a donor, to be patient and be aware it might not eventuate. So I'm just going to finish with, there's a whole team involved in assessing a potential kidney donor. But number one thing is it must be voluntary. You can't coerce, or you can't be coerced into doing this because there is so much involved. The transplant coordinator is the contact person and can be the liaison and help you with all of your tests and organise some appointments for you. We always try for there to be an independent team of kidney specialists and surgeon who review a donor from the recipient's team, so that the assessment is completely independent and not influenced by what's happening with the recipient. Michael said before that he did his workup in about 4 weeks. That's very quick. It usually probably on average takes probably around 6 months. However, it's driven by the donors. So obviously at the moment, things might take a little bit longer because of COVID and getting appointments. However, some people, if they're really motivated and stuff, can get through the process quicker. But some people want to take their time, and that's completely fine. Because it is voluntary and it is driven by the donors, what we say at our unit is that we won't chase you to do tests, but when you want to get to the next stage and you want some help booking your next stage, then we're more than willing to do it. But we won't chase you if you don't want to do it. So, but we do try and streamline the workup process as much as possible so that you're not coming back and forth into a hospital all the time, or you will have to have quite a few blood tests and urine tests, and x-rays and things, but we'll try and do it streamline it as much as possible. But remember that donors can withdraw at any time. And that can be right up until the time of the operation. Oh, I've gone the wrong way, sorry. So this is a very busy slide, and don't take much notice of it. This is just sort of like our pathway that we go through. As you'll notice at the beginning is really the transplant coordinators and with a little bit of help from your GP and the nephrologist, from which I put Kate next to that because she's going to talk a little bit about that. And then transplant coordinators in the social work and psychiatry review. And then basically, and then the surgical review, which Chris will go to. And then down the end, is your donor suitable, yes or no? And so if you do have a suitable donor, then there's the next decision of how to go ahead. Do you go ahead with a direct live donor transplant to your recipient, or there is the potential for the Australia and New Zealand paired kidney exchange? And so then the next stage is the operation. So that's it from me.
Thanks so much, Emma. I mean, that was very comprehensive. I mean, obviously, some people are wanting to focus on the lifestyle changes, and we've had various questions come into the chat. But I think what I might do is hand over to Kate, and then we can take the questions more holistically rather than just being specific at the moment. I should just say, we've had this problem with the web hosting, and we've only got 100 people online, whereas almost 400 people registered. One of the people who can't get online is our kidney transplant surgeon, Christine. And so Dr. Christine Russell is unable to join us, so we don't have her perspective. So if I think probably Michael covered a lot of the surgical issues. Maybe if there are other surgical issues, and there may be some that I see in the questions, we'll come back there. But that's a problem. We may need to run the webinar again for other people. But at the moment, I'll hand over to Kate, Professor Kate Wyburn, who's the Director of Transplantation at Royal Prince Alfred Hospital in Sydney and the President-elect of the Transplant Society of Australia and New Zealand. So, Kate, if you could take over and perhaps move into the surgical aspects as you feel comfortable in doing.
Thank you very much, Carol, and thanks for the opportunity to be here. I was going to concentrate on the role of the nephrologist, and for me, it's an absolute privilege to be involved in this area. Normally in medicine, we're faced with a lot of challenges and problems. When it comes to living donation, we're all often presented with the ultimate solution. And, it's a real lifeline to potential recipients, and that was so beautifully described by both Julie and Michael. So it is a true privilege. It's not to say that it's not a complex pathway, and there are many challenges. And as has been mentioned, sometimes up to 50% of pairs don't necessarily make it to transplantation for different reasons. So the medical, the surgical, the psycho-social and the complex relationships all need to be taken together. And I guess that's part of the role that I play. I do have to say that the champions of our potential donor pairs, live donor pairs, really are the donor coordinators, and they're the people that take you from woe to go, and very much are the source of a lot of information. We've heard so eloquently from Emma. But it comes down to so much more than having 2 kidneys and being relatively healthy. It's a rigorous workup, and I think 4 weeks or 3.5 weeks, Michael, for your wife, is a land speed record. And it can be more challenging than that with lots of consultations, but I hope we're able to provide the support. So I see my role as an independent nephrologist, so I would be seeing the potential donor as an independent nephrologist because the recipient has their own nephrologist, and it's to provide a safe place for open discussion to occur, to provide the information that's required, and importantly, look after someone in the longer term too. So there's annual reviews post-kidney transplant. Phil Clayton will talk a bit more about the longer term complications post-donation, but it is really important that there's ongoing long-term follow-up. So my responsibility primarily is to that potential donor, and I am involved in talking to family members as well. And sometimes potentially, as Emma said, there's more than one donor. I did want to remind everyone that you don't have to be a family member, you don't have to be related to be a donor, and you don't have to be blood group compatible. So sometimes people feel that they may be barriers. So we do know that you do better in general with a transplant than you do on dialysis. And we do know that in general you do better marginally with live donors compared to the deceased donors. And I'll just try and share my screen. This is data from the Australian ANZ data report, and it shows on the left the survival post live donor transplants. And so at 5 years, 91% of those kidneys are still functioning. And on the right-hand side is the primary deceased donor kidney transplants, and you'll see that at 5 years, 82% of kidney transplants are functioning. So still, it's less than 10% of a difference, but there is a difference in terms of live donor and deceased donors. And I guess that just highlights the the extra special gift that a live donor can potentially offer. Let's just get back to, I guess, the role of the nephrologist.
Have we lost Kate? Okay, I'm thinking Kate will come back. Yeah, Kate, we lost you for a minute.
Oh, sorry.
After you discuss the difference in live versus cadaveric outcomes.
My apologies. I'll keep going and hope that I stay connected.
Yeah. Thanks.
So I do think it's important to meet the donor where they're at. So some people are fully informed and absolutely committed from the get-go, and other people, I guess, are a little bit more uncertain or seeking information. And I think it's really important to meet people where they're at and to walk them through the process and take them through. So when it comes to considering suitability of a living donor, there are many factors that we take into account, and many that Emma's already mentioned, and they're weighed relatively differently depending on different circumstances. I'm going to focus on living donors, and already Emma's discussed altruistic donors who, as she mentioned, can go through the paired kidney exchange, which does have the advantage of facilitating more than just one transplant. I wasn't going to run through each and every part of the workup, but it really does break down to making sure that cardiovascular fitness, respiratory fitness, so again, being an ex or a non-smoker, that metabolic history and complications are looked at, infection and malignancy screening is all part of the workup process. And then there are some additional consultations that are required if any abnormal findings come up during that process. In the interest of time, I was just going to mention sort of three factors that I suppose often come up.
What dreams possible tomorrow? Sun Super, what dreams are made of.
And they really are age, comorbidities, and what happens when things don't progress. Oh, my screen.
They love supporting local farmers and suppliers and stocking the special things that locals are looking for. Well, better watch it.
So I'll quickly mention age, comorbidities like hypertension and diabetes, and what happens when a donor is not suitable. So as has been mentioned, age in general, a younger donor has a better quality, for want of a better word, kidney, and you might surmise that we prefer younger donors. It's not really the case. And a younger donor, really, we do need to make sure that they're going to be okay for the rest of their life. So, a 25-year-old donor, you need to know that they're going to be okay for the next 60 years. And so while we do the workup that tries to predict any issues that may arise, we don't have a crystal ball. So it's one of the issues that I think is important to talk through. The other issue with age, particularly for females, so a younger female who is yet to have a family, that's something to take into account. It's not an absolute contraindication to being a donor. And again, I think Phil might discuss some of the long-term implications of donation and later pregnancies. Similarly, if there are two potential donors and one is older and one is younger, you might opt for the older donor because 15 or 20 years down the track, when you may need a second kidney, then perhaps that once was younger donor might still be available. So they're the age considerations that we take into account. When it comes to comorbidities, and really this is the crux of the medical suitability, and the decisions are often interlinked with age, it is considered really in the context of a balance of risk. So if we compare a donor who has hypertension that's controlled on one agent and let's say impaired glucose tolerance tests, so like pre-diabetes, who otherwise has good health and good kidney function. Now, if that donor was 35 years of age, I would be quite concerned about the long-term risks. So what's going to happen over the next 50 years with those comorbidities? And you'd probably advise them not to be a donor potentially. And in fact, if I had a 35-year-old potential donor who had a strong family history of those conditions, but did not yet have them themselves, and a family history of complications from those conditions, then again, you'd be quite circumspect about being a donor potentially. And on that note, we do have a genetic and a dual trained nephrologist and geneticist who often helps us with people with genetic conditions, be that end-stage kidney disease genetic conditions, when there's a family member who would like to donate. If that donor who had pre-diabetes and hypertension was 69 years of age, and otherwise fit and well, then you would certainly consider them as a live donor pair, because the risk of progression over the next 10 or 15 years is probably minimal, and there's significant potential benefit to that pair. So just in the interest of time, I'll talk just briefly about the role of the nephrologist if that potential donor is not suitable, or if a direct path is not suitable. And it can be quite challenging and emotionally fraught, the whole process. And as I said, up to 50% of donors cannot directly donate. And non-suitability may relate to tissue typing, to medical issues, surgical issues, psychosocial issues. The surgical issues, which I won't touch on too much, I would do Chris a disservice, but can be in particular the vessels and comorbidities that affect the vessels, or if there are a number of arteries or veins to each of the kidneys. Sometimes also people come forward and they have uncertainties at the start, and even after a number of consultations, if people are still not particularly comfortable with the situation, I think that's another important issue to pick up, to discuss candidly, and where appropriate, not to proceed. And again, it's my duty as the primary nephrologist to the potential donor to be supportive of that. So if there are issues that can't be worked through for whatever reason, it's really important that all the support that we can is provided to the donor. Or if there are reasons that we cannot directly donate, that we do think of the other options like the Paired Kidney Exchange program, which is a fabulous program. So because we're going on to after 8 o'clock, I'll stop there and make way for Phil. I just wanted to thank everyone who's online, and it is such an amazing path to consider. Live donor provides a great degree of options and ultimately the greatest benefit to people waiting for a transplant, and obviously without any of you, none of this would be possible. So thank you, and I'll hand on to the next speaker.
Thanks so much, Kate. That was fabulous. I think we've had a couple of questions about people who smoke, people with hypertension, what do they need to do after, they donate, that we might pick up in the question and answer. I think Christine is still not on as far as I can tell, but Michael has generously suggested he might be able to talk about some of the surgical aspects that are beyond his personal experience of surgery. So that would be great. I really appreciate that, Michael. I realise there's vascular surgeons and urologists that are involved in transplant, but obviously you have a better perspective than anybody else on this webinar. So I'll hand over to you to discuss some surgical issues. Thank you.
Just briefly covering everything. It's a reasonably big operation. In general, it would take between an hour and a half and 2.5 hours. As I demonstrated from the picture of my tummy before, it's nearly always done through keyhole surgery. If I'm taking a kidney out for cancer, you can ride slightly roughshod over the kidney once it's removed, but that's obviously not what you want to do with a donor nephrectomy. And as a result, you do end up with a larger incision. And once again, through personal experience, it does hurt a little bit more. In terms of the decision making, one of the main investigations that get performed is a CT scan, which clearly looks at the arteries and veins. The kidney typically has one artery and one vein, but up to 30 people have aberrant anatomy, and some people have 2, even 3 or 4 arteries and a couple of veins, which certainly needs to be taken into account in the decision-making process. One of the nice things is with the modern technology, you really are prepared when you go in. With the operation, it does involve mobilising both the large bowel and small bowel. You have a catheter in for around 3 days afterwards. If the job's done well enough, the wound gets nicely closed up. Obviously, as with any operation, there are risks of bleeding and infection. Obviously, you'll have 3 or 4 teams in hospital watching you like a hawk. So you actually get, everyone keeps an eye on things very closely. In terms of any of the specifics, look, for the people online tonight, look, I have been involved both from a vascular aspect and a urological aspect. Obviously, with the ureter, you need to try and make sure that you keep some nice tissue around the ureter, which allows there to be good blood supply. So the donor ureter can be plugged in to the bladder. And look, if there are any specific questions that anyone in the audience has, I can probably answer those later on for you, Carol. I think you're on mute, Carol, sorry.
Mute, actually. Yes, there are a couple of questions about scrotal swelling. We might come back to that when we get to the discussion. So I think we'll probably move on to the long-term outcomes and then get to the questions. So if I can introduce then Phil Clayton, who's an associate professor of transplant nephrology and epidemiology at South Australia, working in the ANZ data, which is where we put all of the data that is relevant to people with kidney disease on dialysis and transplantation. So Phil, I think, was originally recommended as he was the guru of ANZ data, and he said maybe take it down a peg from that. But I think most people regard Phil as the guru. So handing over to the guru.
Thank you, and thanks very much for the invitation to speak. It is, I'd just like to echo what the other speakers have said, it's fantastic to have this group here and to have the opportunity. I'll just remind everyone who's speaking, please. And can I just check that everyone can see my talk?
Can see your screen. There's a few people that probably need to mute.
Yeah. Okay, so I'm going to talk about long-term outcomes of donating a kidney. So things that we might worry about, that you might worry about, and things that we as health professionals might worry about. Although hopefully by the end of the talk, you'll agree that most of them we don't need to worry about. So things that we might worry about would be reduced kidney function, high blood pressure, protein in the urine, obviously the development of kidney failure, whether there's any impact on your survival or your life expectancy, cardiovascular disease, bone health, because we know that having reduced kidney function can impact on bone health, effects on potential future pregnancies, as well as psychological and quality of life changes that may occur following donation. Okay, so this is looking at kidney function. This is from a study that combined a number of other studies. And what it showed was that people who donated kidneys overall had a slightly lower kidney function than so-called controls, which are people that haven't donated kidneys. And it was actually only lower by about 10 mils per minute. Normal kidney function in healthy young persons around about 100. So a difference of 10 is actually not that high. But of course, it will drop if you donate a kidney. And this shows kidney function over up to 13 years following donation in donors who are either under or over 60. And what you can see is at the very beginning, of course, kidney function drops on day one because you've just taken out half of your kidney function. But then over time, up to 13 years later, the kidney function doesn't drop further. And if anything, it actually improves over time. And what you generally end up with is around about 70% of the kidney function that you had before you donated. So the remaining kidney picks up and actually does a bit more work. If we look at blood pressure does go up after donating a kidney. So again, this is a pooling of other studies, and overall, on average, the blood pressure, increased by about 6 in the systolic blood pressure, which is the top number. So if it's normally 120 over 80, it might go up to 126. It is reasonably common that donors will need to go onto blood pressure medication in the years following donation, not usually straight away, but in the years following donation. Although bear in mind that it is quite common for everyone to go on blood pressure medication over time. It's certainly not a huge difference in blood pressure, and it's easily treatable. Protein in the urine does occur quite commonly after donation. It's usually a small amount of protein. We worry about it as kidney specialists because we know that protein in the urine can be a marker of further decline in kidney function and predicting that someone might be more likely to develop kidney failure. But interestingly, that's in people who've got underlying kidney disease. That protein in the urine is quite important. But in donors, it doesn't seem to be as important unless they get a lot of protein in the urine. But a small amount of protein, such as on average here, 66 milligrams. Normal in a day is up to about 150 milligrams. So 66 milligrams is not a huge amount. And typically that will remain steady over time. But that is one of the things that we like to monitor over time. Kidney failure obviously is a very important outcome that we try to avoid, but it does occur. Bearing in mind, we can't sort of prevent everything. So this is data out of America where they had, believe it or not, 96,000 donors in this study. And at 15 years after donating, there were 30.8 donors who had kidney failure for every 10,000 donors. So it's a very low risk. It's about 3 or 4 in 1,000 at 15 years, but it is not 0. Now, if you look at the general population risk of developing kidney failure would be pretty similar to that. The donors, if they hadn't donated, would probably have a lower risk, would be expected to have a lower risk than the general population. But after donating, it probably does go up a little bit, but it pretty much goes up to about what the general population's risk is. Now, this number, obviously it depends on your perspective whether you think that's a low number or a higher number, but this is American data. And one thing I like to point out is something's a bit different in the US from Australia. The incidence of kidney failure, so the number of people who develop kidney failure every year in America is over 3 times what it is in Australia. I don't really know why, but just bearing in mind that if we were to extrapolate this slide to Australia, it may look different. It probably would look different. But how different, I'm not really sure. So a number of people did quite a lot of work where they combined different groups of people with chronic kidney disease and looked at the likelihood of them progressing to end-stage kidney disease in order to try and work out if we could predict the likelihood of donors progressing to end-stage kidney disease, which we obviously want to avoid. And what it looks like that the things are that predict the likelihood of development of kidney failure are having a lower kidney function, which is pretty self-evident, having more albumin in the urine, so more protein in the urine, as I mentioned earlier, high blood pressure, current or former smoking, diabetes, and obesity. And you'll note that it's not any coincidence that those are all the things that Kate mentioned that we'll be looking at in donors and looking at especially the combinations of those risk factors that may make us concerned about someone donating because they would be at higher risk of kidney failure. But interestingly, the one thing that actually gave you the highest projected lifetime of kidney failure was being young at the time of donating. And that's for the reason that Kate mentioned, that you just got many, many years in order to develop problems. And this was just going into the obesity. This was one study out of the US again, where they looked at the risk of kidney failure over time in obese and non-obese donors. And you can see it was actually about double in people who are obese. And that's because of multiple reasons, including putting more of a strain on the kidney and also having a higher likelihood of high blood pressure and diabetes. And Yeah, I'll just move on from that. Okay, what about overall survival? So that was talking about kidney failure, but what about life expectancy? It doesn't look like there's any difference, or if anything, donors seem to live longer than people who didn't donate. So this lower curve here is controls from the general population, and the survival is less. So donors are doing better. That was from one big single center in the US, and this is from American population data where live donors had a lower risk of dying over 12 years compared with people who had very similar age and sex and health problems. So we don't believe that donors are at increased risk of dying. There's also no increase in cardiovascular events, so heart attacks or strokes or heart failure. In terms of bone health, we know that people with low kidney function are at increased risk of low bone density and fractures, but that appears to be if you've got kidney failure due to kidney disease. Whereas in donors, there doesn't appear to be any difference in fracture risk. In that particular study, there was no difference in prescriptions of bisphosphonates, which are medications that are used for osteoporosis. So that's quite reassuring that bone health is probably not impacted by donating. But one thing that is quite important, and Kate brought this up earlier as well, is pregnancy. And pregnancies after donation are more complicated than pregnancies with two kidneys. And we see this in people with one functioning kidney for other reasons as well. Essentially, when you're pregnant, it's a bit of a stress test on the kidney. You've now got two kidneys working for two people instead of one. So if you donate a kidney, you've got one kidney working for two people. And so the likelihood of a full-term birth went in this study from 85% down to 74%. Fetal death was doubled. Gestational hypertension. Sorry, I take that back about fetal death. Just correct myself there. But miscarriages were increased. But for the mum, high blood pressure went from 0.6% to 6%. And preeclampsia or toxemia increased from less than 1% to 5.5%. And protein in the urine was increased by 4 times. So pregnancies after donation are definitely more complicated than pregnancies before donation. So it's definitely worth something. It's definitely worth considering this if you are a potential kidney donor who may get pregnant in the future. In terms of psychological impacts of donation, depression it can occur. It's more likely to occur if the recipient does badly. So if they lose their kidney transplant from rejection or some kind of technical problem, or if they die. Although overall, it's actually less common than in matched controls. So people who didn't donate a kidney. And quality of life can have some complicated changes. A lot of donors describe that the way they think about themselves can change a bit. Their roles in family and relationships can change a little bit after donating. It's usually a positive thing, almost always a positive thing. And the overall quality of life in donors in the longer term is quite similar to the general population and in healthy controls. Just to mention the ANZData Living Donor Registry. So ANZData, as I think Carol mentioned, is a registry that's based in Adelaide, but collects data on everyone in Australia and New Zealand who's on dialysis or has had a kidney transplant on an opt-out basis. And since 2004, it also collects information about living kidney donors. The aim is really to describe the practice patterns of living kidney donation in Australia and New Zealand, to describe relationships between donor factors and recipient outcomes, and also to monitor the short and long-term risks associated with kidney donation. And in order to understand the long-term risks associated with donation, we collect annual follow-up information on donors. Unfortunately, the annual follow-up information that we ask for is not really reported all that well. So these are the proportion of donors with follow-up reported to ANZData. And you can see that at 1 year, it's sort of around about 70% of donors that we have some information on. Once we get out to 5 years, it's less than half of donors. It's not really getting better over time. So we certainly encourage everyone who donates to contribute to the registry, because one thing you may have noticed is that all of the information I presented today didn't come from Australia. And it would be really great if we could present Australian data because that's what is really most relevant to Australian donors, not American data. So just to conclude, the long-term outcomes of donors, their health is as good or better than the general population. There is a very low risk of kidney failure after donation. We do screen donors quite heavily. However, the risk is not zero. is probably similar to general population. We do need long-term Australian data to be able to give better information, and we have a registry for that purpose. So thanks for your attention.
Thanks so much for that, Phil. I think that would reassure most people that living donation is still a very viable prospect. I think we've got a couple of questions that I might pose to the audience, or not to the audience, to the panel on behalf of the audience. Maybe I'll direct this first one to Kate. We have a question about when is the best time to donate or to consider donation. Is it in CKD stage 3, 4? You know, when should people be putting their hands up to be assessed as donors?
Oh, that's an excellent question. Thanks so much. It can happen at any time. I think probably stage 3 is probably a bit on the early side and it just depends on rates of progression, but certainly live donors can donate and allow for preemptive transplant. So ideally, we would love to be able to transplant everyone before they require dialysis. So a preemptive transplant when the GFR is around that sort of, 10, maybe even up to 15 mils per minute. And to be able to do that, you do need to be thinking about live donation when the GFR is sort of falling around that sort of 20 and below mark. The workup process can be protracted, and it might be that first donor that comes through is not able to donate. So being ahead of the game never hurts, and even if it's just to be informed and to raise the option, I think that's really important, and that can be done almost at any time. You can also donate, obviously, when someone's been on dialysis, later down the track, but ideally, preemptive transplant from a live donor is probably one of the best options.
Mm-hmm. That answers a couple of questions, so that's great. Maybe if I can turn to Michael Wines, and there is a question about scrotal edema after the operation, and nobody mentioned that, and is that a common complication?
Quite a lot of people have undiagnosed or very small inguinal hernias. So when you're doing the procedure, you actually blow up the abdomen with carbon dioxide, and some of that carbon dioxide can actually track through into the scrotum and actually blow up the scrotum a little bit like a small balloon. That normally settles down over a couple of days. The other reason that you can get scrotal, well, two other reasons. One, if some bleeding occurs and some blood tracks down into the scrotum. And the third reason, sometimes when you have a catheter in, which you will for a couple of days, you can get a urinary tract infection, and that can track down the vas, the tube that the sperm come up, and lead to an infection in the testes. So that'd be the three reasons that somebody would most likely have that. Certainly that wasn't a problem for me, although I did have some bruising certainly below the scar that I showed you.
Mm. Yeah, so I think that everybody has an individual risk, but it's not like everybody ends up with that same complication. So that's very helpful, Michael. I guess we've got another comment here about people that are not immediately suitable to donate to their partners, and what are the options outside of the kidney exchange program. So, sophisticated question about plasma exchange and other strategies to reduce sensitization. So handing over to you, Kate, on that one.
So I suppose I'm assuming that the question relates to the reason you can't donate is because of sensitization.
I'm assuming so, or
yeah,
because
so,
maybe blood type. It wasn't clear.
if it is purely sensitization, then we would primarily direct to the paired kidney exchange program. Very few centres now do formal desensitization, and that's because it is quite a rigorous process, and the success rates are not as good. So when you can potentially go into the paired kidney exchange program and get a donor who you are compatible with, that would be the best immunological option. And now that the paired kidney exchange program runs almost continuously, there's not the long waiting time, which was often one of the detractors for waiting. It blew out the waiting time a little bit in terms of the match runs. If the question is not just about sensitization, but you're unsuitable for other reasons, in some cases, people have not been suitable as donors because of obesity or because of impaired glucose tolerance tests or other lifestyle factors such as smoking. And we've really intensive behavioural changes, so people have lost significant amounts of weight and even reversed from being pre-diabetic to having normal glucose control, and people who have stopped smoking and lost weight. And it's a hard road, but lots of people have done it and are very motivated. So there are some people that potentially become suitable after the first assessment would suggest otherwise.
Mm-hmm. And if I can just extend that, are there forms of kidney disease that you would be less likely to accept a related donor as opposed to an unrelated donor?
So there certainly are, and I think that's the genetics of it is becoming much more well understood, and we're understanding it to the point where we can be more clever with our decisions. So I guess for some people that have IgAs or minimal change or other glomerulonephritis diseases that can have genetic components, then we can actually do the genetic studies and see if there's a link. Similarly with HUS, other types of genetic kidney diseases, we can look at the genetics specifically rather than just saying you're related, so the increased risk exists. We can sometimes delve into that quite specifically and find potential relatives who don't carry that gene or those genes at risk. Having said that, if you have the the option of a non-related person, then you go down that path.
Sure. Okay. And I guess if I can just come back to Emma and just to ask Emma about some of, another question that we have about confidentiality, about, people that put themselves up and then maybe go through the process and then they might be suitable, but they don't want to donate. Then what happens?
Sure, I mean, that does happen a bit. As Kate said, or Michael said, that he didn't, him and his wife went through part of the process before telling their neighbour and the ultimate recipient that they were being worked up. And we do that quite regularly. So a lot of, some people aren't quite sure if that's what they want to do, or they also, if they're deemed not suitable for some reason, they don't want to disappoint the person that they were potentially being worked up for. So, so we would, if that was the wish of the potential donor, then we wouldn't say anything to the recipient about them being assessed as a donor. And then if somebody's potential recipient does know that they're being assessed and then changes their mind, but they don't want to tell them that that's, that they've changed their mind or that they don't want to do it, we can potentially give a reason or a medical or an out for them, because some people are worried that it's going to affect their relationship with that person. So we can give them an out for that if that's what they wish.
Thanks very much. Look, we've got one more minute. I think that there's a question about pain relief. So maybe I'll direct that to Michael. We don't have a pain relief person online. So Michael, can you talk to us about how your pain relief was sorted?
That hurt. I was in quite a lot of pain. Not going to underestimate that. Morphine and endone, I don't particularly like. I had a response to that, had to get changed over. I thought I was a tough guy. I didn't press the button for the PCA, the remote control, because I'm a tough guy. I then felt terrible. I then pressed it too much and then felt worse. Things settled down the following day. Most of the teaching hospitals that this would be occurring in would have a pain service where people would come and round and assess things. And certainly after 24 hours, things were settling down. But look, I was pretty dopey and pretty hopeless and ended up spending 5 days in hospital when I had the expectation of being out in 3 or 4. Certainly I was pretty happy to be getting out of the hospital a few days later. So I was pressing one of the buttons for 3 days. I then transferred onto oral tablets and then went home on oral tablets. And I don't like taking tablets very much. I was keen to get off them. And I think by about day 10 or day 12, I was certainly nothing more than paracetamol.
Oh, that's great. Thanks, Michael. I think that pain relief is something that often doesn't get discussed early enough. And so for people to hear about that, that's really important. So look, we're at 8:30. I understand from the Transplant Australia people that they've recorded this that may enable people who couldn't join the webinar to be able to see it. I think it's been a really fantastic discussion from a multiplicity of views to support living donor transplant. I think hopefully everybody's seen that as nephrologists and the transplant community, we are really keen to support living donor transplantation for our patients. I think, as Kate said, it's the best part of our job. You know, the fact that people have kidney disease and then they don't have kidney disease by virtue of somebody donating a kidney is, yeah, it's fantastic. So I hope everybody's gained something from today's webinar, and there may well be an appetite to have a similar webinar down the track. So I just want to thank everybody for being involved and everybody for participating, and we might do it all again soon. So thanks for all the support from Transplant Australia and their supporters, and for the individuals.
I was going to say thanks, Carol, and we'll now just cross to Colin Liebman to close off today's session. Great work, and thank you for chairing it, Carol. Colin.
No trouble.
Thank you to all of our highly valued speakers that we heard from tonight: Julie, Carol, Michael, Emma, Kate, and Phil. We admire and appreciate your skills, your dedication, and your care. We appreciate you giving your time tonight to share your insights. Living donors are special people. They make a profoundly generous decision to change a family member, friend, or even stranger's life. Recipients are courageous, people who find the strength to survive and flourish through the bad hand they've been dealt by genes, disease, or luck. Our medical professionals change their lives through the miracle of transplantation. We at Transplant Australia's Living Kidney Donor Program hope you all enjoyed this webinar. We are a volunteer group of living donors or people touched by living kidney transplantation. I was drawn to the group 4 years ago when my 19-year-old son received his mother's kidney. It was a very confronting experience, and we appreciated the support and counselling from the Living Kidney Donor Program. We aim to promote living kidney donation, and we educate and support donors. This is one of a series of webinars that Transplant Australia has organised. We've also embarked on producing a series of videos documenting the stories of donors and recipients. These are for the benefit of prospective patients as they approach workup, surgery and recovery. They address frequently asked questions collected by transplant coordinators. The first two, featuring Michael and his brother Richard, are on our Patient Stories webpage. We aim to capture the diversity of experience and circumstances in future videos, so all patients will find something to relate to. Thank you, Richard, Julie, Maddie and Chris from Transplant Australia for organising tonight's webinar. Thank you to our partners for promoting it. And thank you to all who have dialed in to listen and participate. And we look forward to welcoming you all to the next webinar or event. Good night.